So the next talk we will have Dr. Angtuaco to give us lecture on the fatty liver evolving public health crisis. Dr. Angtuaco graduated from University of St. Thomas in Manila, and then he completed his residency in Mount Sinai, and then fellowship in Russian University in Chicago, and came here served as assistant professor in UMS, and then joined actually ARDC in 2015, and in 2018 he founded Premier Gastro over here, and he actually also a writer. He actually wrote 2 very inspirational books. I actually read all of them. So check them out, really inspirational. Now, Dr. Angtuaco.
Thank you. So first of all, Sean, you were very impressive. You memorized my whole biography. That was very impressive. So first of all, thank you very much. I'm very honored that you invited me to join this great group of speakers to give a lecture today. I'm very honored and grateful for that. So I have my name and cell phone number up there, so everyone is welcome to text me, call me if you need anything. Like I always say, in my practice, 1 phone call is all you need. Just call me, give me the patient's name, number, I'll take care of everything. So I would also like to acknowledge my 2 kids. They're not kids anymore. So my son Tyler is a first-year medical student at UMS. So I brought him here to introduce him to the medical community here, hoping that after he finishes med school, residency, fellowship, he would come back to Arkansas and take over my practice. And my daughter is Julia, and she's a sophomore student, pre-med student at Notre Dame in South Bend, Indiana. So hopefully she comes back to Arkansas for med school and stay here with us in Arkansas. So the topic today is on fatty liver disease. Compared to what I've heard Dr. James' lecture and Dr. Ingram's lecture, my lecture is extremely simple and basic. You guys will not have any complex mental exercise here. I'm just gonna spit out all the information to you. But mainly, my goal today is to achieve 3 things. So, first, I want you to understand or keep in mind that fatty liver disease is a very prevalent disease in this country or maybe in the whole world. Number 2, I would like to impress upon you that fatty liver disease is not a benign disorder as a lot of people take it for granted. It is not a benign disorder, and we need to pay attention and be proactive in taking care of this disease. And lastly, it's a call to arms that we all have to come together and be proactive in coming up with ways to manage this disease, because this is indeed a public health crisis. I recall 22 to 23 years ago, I was a professor at UMS, and I gave a grand rounds lecture on fatty liver disease. And at that point, fatty liver disease was already a public health crisis, but 20-some years later, it is even worse. So I'm going to go about convincing you this afternoon that it is a significant disease, significant public health crisis that we all have to pay attention and do our part in trying to manage this disease. Which one do I?
Oh, right.
So is fatty liver disease really a public health crisis? So in this epidemiological study, fatty liver disease was found to be the most common cause of chronic liver disease. Up to 25% of the world's population has fatty liver disease. in comparison to hepatitis C, which is already pretty prevalent, hepatitis C exists in about 0.5 to 2.5% of the world population. Hepatitis B, 4.1% of the world population, and alcohol liver disease at 4.8% of the world's population. So fatty liver disease is significantly a major health problem. And as far as liver transplantation is concerned, fatty liver disease is the second most common indication for liver transplant in the United States, only second to hepatitis C. And fatty liver is also among the top causes of hepatoma, alongside hepatitis B and hepatitis C. Fatty liver, non-alcoholic fatty liver disease, or NAFLD, is what I'm going to refer from here on. NAFLD is closely linked to type 2 diabetes and obesity. And as the rise in obesity prevalence goes up and the prevalence of type 2 diabetes goes up, so is the prevalence of non-alcoholic fatty liver disease. And it is estimated that by 2030, it will increase 2 to 3 folds from what it is currently the prevalence. And with that, with the prevalence of NAFLD, there will be increase in cirrhosis and complications of cirrhosis and death from liver disease. So I understand most of you here are endocrinologists or primary care physicians. So how relevant is NAFLD in your practice? An epidemiological study across 20 countries showed that NAFLD is present in more than 50% of patients with type 2 diabetes. So these are the patients that you see a lot, and therefore you need to keep in mind that more than half of these people you treat for diabetes might have fatty liver disease. And in another survey of outpatient practices, which include family medicine, internal medicine, and endocrine practices, 70% of type 2 diabetes have NAFLD. And of these 70%, 15% of them have significant liver fibrosis. So cirrhosis is stage 4 fibrosis. So any fibrosis stage of 2 and above is considered advanced fibrosis. So 15% of these patients in outpatient practices have advanced fibrosis, meaning they are likely to develop cirrhosis and complications thereof. So it begs the question, how can we fix something if we don't know that there's a problem? And so in a survey study of patients who have eventually found out fatty liver disease, less than 5% of them were aware that they have fatty liver disease, as opposed to people who had viral hepatitis, so hepatitis C or hepatitis B. These patients, 38% of them were aware that they have viral hepatitis. And another survey study showed a significant knowledge gap in primary care physicians and endocrinologists about the significance of fatty liver disease. And this is a study of 2,200 physicians. And in a US survey of 751 primary care physicians, endocrinologists, and gastroenterologists, they found that majority underestimated the prevalence of fatty liver disease in patients who are obese or have type 2 diabetes. That's actually an important point. Gastroenterologists, I'm a gastroenterologist, but I'm a hepatology subspecialist. A lot of gastroenterologists do not understand the significance or do not give credence to fatty liver disease. And that's why I use the statement, fatty liver disease is not a benign disease. Although I'm not talking about cancer, benign or malignant, I'm talking about benign meaning something you can take for granted. Not every gastroenterologist would want to see a fatty liver patient. Not every gastroenterologist recognize that fatty liver disease is an important disease. In fact, some of my colleagues refuse to see patients when they're given a referral for elevated liver enzymes because they feel, oh, everybody has elevated liver enzyme. But that's not the point. Just because a lot of people have elevated liver enzyme and just because a lot of people have fatty liver disease doesn't mean that they're not a significant problem. So, and another study showed that diagnosis of fatty liver disease and referral to specialists were low among endocrinologists. So, NAFLD, so we have to make a distinction between AFLD. AFLD is alcohol fatty liver disease, as opposed to NAFLD, which is non-alcoholic fatty liver disease. And the only difference between the two is one subset, the AFLD people, drink significant amount of alcohol, and the NAFLD people did not drink significant amount of alcohol. And then we need to make a distinction between NAFLD and NASH. And the importance of that is NAFLD is when a patient's liver has steatosis, meaning more than 5% of the hepatocytes are involved with steatosis, but they do not have inflammation or fibrosis. Patients who have NASH, non-alcoholic steatohepatitis, there has to be a component of steato, which is fat, and inflammation, which is hepatitis. So on a liver biopsy, these patients will have balloon degeneration. So balloon degeneration suggests active hepatocyte injury. And then the NASH patients also have significant fibrosis, meaning stage 2 fibrosis and above. So in order to make a diagnosis of NASH, it has to be done through biopsy. So NASH is a histologic diagnosis. We cannot look at a patient's ultrasound and say, you have NASH. The patient has NAFLD, but you don't know the patient has NASH. But the problem is we can't just do liver biopsies on everyone because it's an invasive procedure and we don't have a treatment. So that's the moral dilemma there. I would love to do a liver biopsy of everyone and make a diagnosis of NASH, but I cannot justify doing that in the absence of an effective treatment. So, and the next important thing about differentiating between NASH and NAFLD is that only 2% of patients with NAFLD will progress to cirrhosis, as opposed to 20% of patients with NASH will progress to cirrhosis. And so if somebody has NASH, these are high-risk patients. So in a study of asymptomatic patients undergoing colon cancer screening, 12 to 14% of them were found to have NASH. And in patients who have type 2 diabetes, NASH was present in 30 to 40% of them. And in those who are obese, 25 to 30% of them have NASH, as opposed to just NAFLD. So I made a distinction between ASH, or AFLD, and NASH. So what is considered significant alcohol intake? This is always a subject that is very sensitive to patients because they feel they're being judgmental. But from our standpoint, it's about assessing their risks. So significant alcohol consumption is defined as more than 21 standard drinks per week in men and more than 14 standard drinks per week in women. Women are more susceptible to alcohol injury than men. It has nothing to do with sexism or what, but it's just physiologic cause. Or more than 30 grams per day in men and more than 20 grams per day in women. So I looked up gram per ml of these different alcoholic beverages. Beer is 5 grams per 100 ml, so a standard 12-ounce can will have 18 grams of alcohol. Wine will have about 48 grams of alcohol per glass, and an 80-proof liquor will have about 18 grams of alcohol per shot. So in other words, in men, drinking 2 cans of beer a day is considered significant. Drinking 1 glass of wine a day is considered significant. and drinking 2 shots of liquor a day is considered significant. And in women, drinking 1 can of beer a day is significant, half a glass of wine a day is significant, and 1 shot of liquor is considered significant. And these are significant in terms of from the point of diagnosis. So if I diagnose a patient with fatty liver disease, I ask them their history the past 2 years and see whether they have significant history of alcohol within the past 2 years. And if they do, then they're labeled as ASH or AFFLT, as opposed to NASH or NAFLT. So the pathogenesis of fatty liver disease. So typically, if the caloric consumption exceeds one's ability to dispose of these metabolic nutrients and exceeds their need for the nutrients, then there is accumulation and formation of fat in the liver. So that is called de novo lipogenesis, which you all are the expert and I'm not. And so when there is increase, and also when there is an increased caloric intake and there is oversupply of fats to the adipose cells, then this fat storage capacity of the adipose cells get stressed, and therefore they activate the inflammatory pathways. And with that leads to insulin resistance and lipolysis, which releases free fatty acids in the circulation. And so when there's increased free fatty acids in the circulation, they're taken up by the liver, and so the liver will have an increased supply of free fatty acids, and that causes oxidative stress. There's generation of these ROS, or reactive oxygen species, which then overwhelms the natural antioxidant defenses of the liver. And with that, inflammation happens, and with that, fibrogenesis happens. Therefore, you have fibrosis and scar tissue formation, and as it progresses, you develop cirrhosis. And so other than environmental factors, dietary factors, there are genetic factors. There are some subgroups of patients who have certain genetic polymorphisms that make them more susceptible to fatty liver type injuries. But that's beyond my scope of expertise. Dr. Graf will probably be here to help you with that. So the risk factors for NAFLD are the following. So BMI more than 28. So obesity is more than 30, but BMI more than 28 is found to be a risk factor for NAFLD. Type 2 diabetes, dyslipidemia, and hypertension. So what I always tell the patients is this. If you have a BMI of more than 28, and you're diabetic, and you have hypertension, or if you have hypertension, or if you have dyslipidemia, it's as if you're drinking alcohol every day without the pleasure of the alcohol. That's the way I would frame it to the patient. So it's bad enough you can't drink alcohol, but if you are diabetic or you have dyslipidemia, it's as if because the injury of alcohol and the injury of NAFLD is exactly identical. They're identical. That's why the distinction between AFFLT and NAFLD, because histologically and mechanistically, the mechanism is the same, the histologic damage is identical. So the only differentiation there is the lack of alcohol for one and alcohol in the other. So what is the most common symptom for fatty liver disease? The correct answer is none. They're asymptomatic. But if we were to nitpick and say, well, some of them will have symptoms, the most common symptom is a dull pain in the right upper quadrant. So patients sometimes do not even talk about it until you ask, because it's a subtle pain. It's a knowing that you have some ache in your right upper quadrant. In fact, some people end up getting unnecessary cholecystectomies because they have right upper quadrant pain, when in fact their pain is liver pain. And the reason is the liver in and of itself does not have nerve endings. The nerve supply is in the Glisson's capsule, the capsule that surrounds the liver. So that's why if I puncture somebody's liver during a liver biopsy, the pain they feel is the pain from the needle traversing the Glisson's capsule. The liver itself does not have any nerve supply. So patients with fatty liver disease get right quadrant pain that's dull. It's because patients with fatty liver disease get hepatomegaly. Their livers are larger, and so the large liver stretches the capsule, and therefore the stretching of the capsule is what causes the pain. And so most of the patients who are diagnosed with fatty liver disease are diagnosed incidentally. So either they come to you with elevated liver enzymes, and then you do an ultrasound of the liver, and you find fatty liver disease. Or they get a CT scan for some other reasons, and then you find they have fatty liver. So who are considered the at-risk population? So not all fatty liver disease are the same. Some people are early stage, some people are considered at risk. So the at-risk population are the ones we need to target and be more vigilant about. So those who have biopsy-proven NASH, they are at risk. And I explained that earlier. Those who have stage 2 fibrosis and above are at risk. And these at-risk population, we need to focus on them because they have higher risk of morbidity and mortality due to liver-related complications. So earlier, I talked about the 20-year duration of progression to cirrhosis in patients with NASH. So that's the data that suggested that. So the fibrosis progression rate was looked at, and patients with pure steatosis, just plain fat in the liver, their rate of progression of the fibrosis is about one stage every 14 years. So from stage 1 to stage 2 takes 14 years. Stage 2 to stage 3, another 14 years. But patients who have NASH, they progress from stage 1 to stage 2 within 7 years. So if they're stage 1 on diagnosis, in about 21 years, they would be cirrhotic, or stage 4. So just as a general rule, I always say NAFLD patients will have a 2% risk of progression to cirrhosis. NASH patients will have a 20% risk of progression to cirrhosis within 20 years. So 20% in 20 years. But the thing with the NAFLD though, they can be NAFLD today and can have NASH next year. That's the challenge there. So we have to target these high-risk population, the people who have type 2 diabetes, the patients who are obese with metabolic complications, those who have a family history of cirrhosis. So in this study, first-degree relatives of patients who have cirrhosis have a 12-fold higher risk for advanced fibrosis. And that is where the genetic factor comes in. Some of them have this PLP, something M2 genetic polymorphism that makes them more likely to get cirrhosis. And obviously, the people who have significant alcohol use, we have to pay attention to that. So diagnostic evaluation of fatty liver. So we do blood tests, so liver chemistry, what we call hepatic function panel, which is a misnomer. They're liver enzymes is what we call them. So we check liver enzymes, imaging studies, so that's ultrasound, CT scan, MRI, FibroScan. So FibroScan is a new technology. It's a non-invasive tool that can quantify the amount of fat in the liver and can quantify the amount of fibrosis in the liver. And I'll talk more about that in a little bit. And liver biopsy, obviously, is the gold standard. So liver biochemistry. The take-home point here is this. Just because a patient has normal liver enzymes doesn't mean that they do not have fatty liver disease. Just because a patient has fatty liver disease on ultrasound doesn't mean their liver enzymes should be elevated. And just because somebody has normal liver enzymes doesn't mean that they don't have cirrhosis. That's a take-home message there. But in somebody who has intermittent or chronic elevation of their transaminases, meaning AST or ALT more than 30 for more than 6 or 12 months, chances are these patients have chronic liver damage. And so I put the 30 units per liter there is because each lab will have different ranges of normal. Some of them up to 60, okay? But just keep in mind, 30 is a cutoff for most specialists, for most hepatologists. The reason is the normal range for these blood tests were validated based on so-called normal people. But these so-called normal people included people who have diabetes and who are obese, but asymptomatic. So just because they're asymptomatic, they're not normal. So the range that goes even up to 60 is not valid from a hepatology standpoint, is because a lot of them in those studies to validate those normal ranges were obese or diabetic. So, but the other thing about liver biochemistry is if there's a reduction of the ALT of more than or equal to 17 points, it's usually associated with histologic improvement. But keep in mind, when I say histologic improvement, I mean lessening of the degree of steatosis, not necessarily fibrosis, or lessening of the degree of inflammation, but not necessarily fibrosis. Typically, fibrosis is irreversible, but there are a few studies here and there that show that fibrosis is actually reversible, but those are few and far in between. FIB score. So the FIB score, so over the years, there's a lot of research studies that were done to screen patients. So FIB score is a very easy to use scoring system to screen patients. So this is ideal for patients, for physicians who are in the primary care setting. So you can get your app, the MedCalc or the MD Calc or MedCalc X, whatever. They have this formula on the app, the FIB4. The FIB4 is based on a formula based on age, AST, ALT, and their platelet counts. So naturally, platelet count is a great indicator because thrombocytopenia indicates cirrhosis typically because of the splenomegaly and eating up of the platelets. And typically, AST, if the AST is higher than the ALT, it's not just alcohol, it's usually suggestive of more advanced fibrosis. So those this is a nice, easy little formula you can use. And so the significance of this FIB4 score is it has great negative predictive value. In other words, it is great in telling you that this patient is okay, that they don't have advanced fibrosis or cirrhosis. So if their FIB score is less than 1.3, they're considered low risk. That is the only information that is significant there. Any other number is hard to interpret, but it's just good to know. In other words, they're high risk if they're more than 2.67, but it's an estimate. It doesn't have a good positive predictive value, but this has a great negative predictive value. In other words, if it's less than 1.3, this patient may be okay if they don't want to drive all the way to Little Rock to see a hepatologist, So ultrasound. So ultrasound has low sensitivity. Although this is the most common first-line test that we do, and we see a bright liver. So ultrasound will show increased echogenicity. So the fat reflects the light, reflects the echo and gives you a white, bright image. So that's called increased echogenicity. It's suggestive of fat. When you see the report saying increased echogenicity, that means the patient has a fatty liver. But the absence of fat, the absence of increased echogenicity on ultrasound does not mean the patient does not have fatty liver disease. Ultrasound is good in detecting cirrhosis. When the ultrasound, if it shows a small shrunken liver, the patient is likely cirrhotic. If the ultrasound shows that the caudate lobe is enlarged, the patient is likely cirrhotic. Because what happens is the blood supply to the caudate lobe is not compromised, and when the right lobe shrinks, blood supply goes to the caudate lobe and feeds it, so the caudate lobe gets larger. It's just amazing how it happens. And so cirrhotics usually have a larger caudate lobe than the rest of the liver. And ultrasound also can show you evidence of portal hypertension, such as ascites. You can see varices. You can see the enlargement of the spleen. So when somebody has an enlarged spleen, it typically would suggest portal hypertension. Although ultrasound is a very poor test because it's very inaccurate. It's operator dependent. So number one, how do you measure the spleen? So if it's more than 12 centimeters, it's enlarged, but how do the tech measure the spleen? They put the probe and they do different angles and they come up with a measurement. So it depends. If the technician points this way more than this way, or this way more than that way, the liver may seem larger because the spleen is a three-dimensional object and it's not a planar object, so it's a mere estimation. So there's a lot of false positive splenomegaly. And patients who are larger size, then they may have a relatively larger spleen that may not be pathologic. So ultrasound is a little bit difficult, but if you see splenomegaly, especially if they have hypersplenism, when their platelet counts are low, chances are they have cirrhosis unless they have any other hematological problem. And if you see collateral vessels, those are the varices that you see. They surely have portal hypertension. But portal hypertension is not all from cirrhosis. Portal hypertension can be prehepatic, which is if they have portal vein thrombus, that's prehepatic portal hypertension. They don't necessarily have cirrhosis. Or people who have parasites and have portal vein thrombus because of parasites, they're not cirrhotic, you know. Or they can have post-hepatic portal hypertension, meaning above the liver. So people who have heart failure and they have passive congestion of the liver, it's a post-hepatic portal hypertension. It doesn't mean that they have cirrhosis. So FibroScan. So FibroScan is a great tool that we're so happy to have. So it allows you to identify the degree of steatosis of the liver and determine the degree of fibrosis of the liver. So we determine the degree of steatosis by the controlled attenuation parameter. So on the FibroScan, we are able to classify the degree of fat as to S1, S2, or S3. So S1, minimal fat, S2, moderate, S3, severe degree of fat. But the ability to quantify the fat is limited when it's beyond 288. So anything 288 and below, you have a certain degree of certainty, the degree of fat in the liver. But again, the degree of fat in the liver is not as important as just knowing the presence of fat, because the degree of fat has no prognostic significance. But for follow-up purposes, when somebody is improving, it may be of significance. Now, for fibrosis, we use a liver stiffness measurement, or LSM, and it uses a technology that uses vibration. So it's called vibration-controlled transient elastography. So again, it allows you to quantify whether they're stage 1, stage 2, stage 3, or stage 4. This is a non-invasive test that is a pure estimate. This is a tool to help guide us to determine which patients to send for a liver biopsy. So, but there's a lot of false positive stage 4 with this test, especially if somebody who has a BMI of 40 and above, or 35 or above, especially 40 and above, the degree of accuracy for the fibrosis measurement goes down significantly. But then, I would rather over-detect it and do more liver biopsy than under-detect it, right? Because I don't want to miss cirrhotic, but I would rather take a biopsy and find that somebody's not cirrhotic. So again, there's also a cutoff. So if the kPa is less than 8, there's a good degree of certainty you can rule out cirrhosis. And if it's more than 20 kPa, there's a high degree of specificity that the patient has cirrhosis.
And is it operator dependent as well or not?
It can be, but with a FibroScan, we do 10 attempts, 10 readings, and then it averages out the readings. And there are different kinds of probe. There are larger probe, shorter probe, but yeah, it's always operator dependent, but not as much as an ultrasound, because it's a one-directional thing. You point the probe you just have to go between the ribs. Some patients, the ribs are close together, it's hard to go in between, those kind of things. So there's another test called liver elastography, which is easily available. You can send the patient to your friendly radiologist, and they can do a liver elastography. It's the same technology. It measures the liver stiffness, but it just lacks the ability to measure the degree of fat or steatosis. And then on the FibroScan, there's also a formula called the CLA measurement that can give you a predictive ability, the ability to predict whether the patient has NASH or not. So all these are just non-invasive tools to help predict. But liver elastography is purely for fibrosis purposes. So liver biopsy is a gold standard. It's costly, it's invasive, and it has significant complications. Based on that report, there's 1 to 6.4% risk of bleeding and pain. So the risk of bleeding is low, but if they bleed, some of them require hospital stay and blood transfusion. Because the liver is a bag of blood. They're puncturing a bag of blood. So there's a risk for bleeding. But it's not very common. So that's why when a patient goes through a liver biopsy, which we all do now under CT scan or ultrasound guidance done by radiologists, their patients are kept for 4 hours for monitoring. They lay on their right side to put compression, which does nothing because you have ribs there, but just to make us feel better, we make them lay on their right side and watch them for 4 hours. Because if they're gonna bleed, majority will bleed within the first 4 hours. And then there's pain. The pain is because they have to make like a 1 centimeter incision. The liver biopsy needle is this big needle that's like a pen. It's a spring-loaded needle. It's like a pen. Literally, it takes less than 1 second. I position, because we used to do it in the office. We're just palpating the spot and trying to avoid the hepatic artery by palpating, which is ridiculous, right? I actually published a paper on that many years ago, more than 20 years ago. I wrote a paper because I already predicted that this is not tenable. And but anyway, my prediction was right, because 5 years after I published the paper, nobody does it anymore. Because you have to palpate, and you try to avoid the gallbladder, and you try to avoid the bile duct, and you try to avoid the hepatic artery. How in the world can palpation, no matter how good you think you are as a clinician, can you avoid those? So anyway, so these days, only radiologists do them. They do it under ultrasound guidance or CT scan guidance. So the risk of bleeding is much less, the risk of hitting the bile duct is less, the risk of puncturing the gallbladder is less. But they have to make an incision, so this huge needle, but only 2 centimeters go in though. This big needle, you just press the button, the needle goes in, comes out, takes 2 centimeters of the liver, and you need to get 14 portal tracts to have a good specimen. But that incision can cause pain, right? And then the other pain is the patient get a right shoulder pain. So you think right shoulder, patients say, why would I get a right shoulder pain? So the right shoulder pain is because you puncture the Glisson's capsule, the liver is a bag of blood, so 1 drop of blood comes out through the hole where you puncture the needle through. As you pull out the needle, you suck out the blood also, and it drips and goes goes beneath the diaphragm and irritates the diaphragm, so you get a referred pain to your right shoulder. So typically I warn my patients, you might get right shoulder pain after the procedure and pain at the incision site. And also when I used to do the liver biopsy myself, the patients usually describe it as a thud on their solar plexus. As the needle goes in, they feel like a big thud. That's all they feel. So the risk of death is 0.2 to 1.6% only. I mean, it's not only. 1.6 is a lot. Okay, so treatment of NAFLD. So the only proven beneficial treatment for NAFLD or NASH is weight loss. There's no FDA-approved medication to treat NAFLD. And so it's been shown that more than 5% weight loss leads to reduction in steatosis. And more than 10% weight loss leads to reversal of steatohepatitis and possibly fibrosis. So there are no FDA-approved medications for treatment because there are only a few well-designed, adequately powered, randomized controlled trials on pioglitazone and semaglutide. So these are the two drugs that have been studied and have decent results, but the results cannot be conclusive because of the number of patients in the study and the duration of the study. So for pioglitazone, the studies were less than 3 years, and the studies on semaglutide, they were less than 1.5 years. So they're far from getting a definitive, conclusive result from those studies. But at least we have something to go by, and hopefully, as the years go by, we'll have more data to show us the strength of these studies. So vitamin E. So vitamin E has been talked about for a long time, and it's been shown that 800 units to 1,200 units of vitamin E for about 1.8 years led to improvement of aminotransferases, steatosis, and inflammation. One of these studies is on pediatric patients. But then about 10, 15 years ago, there was a news item, actually local TV news, and about the vitamin E, because there was some case reports, anecdotal experiences about vitamin E causing bleeding complications like hemorrhagic stroke, and there was some anecdotal reports of prostate cancer. You know how it is in academia. To be able to get promoted, you have to write a paper. So anything you find, you want to write about it, and there's no cross-examination because it's a case study. But then it's out there, it's published, the news media made a big deal out of it, so people got scared, so all my patients who are on vitamin E stopped taking it.
You know, it would make sense that vitamin E would work because of the flurry of free fatty acids being liberated not only from fat tissue, but also the inability of insulin to suppress VLDL particles that are basically carrying triglycerides. And when those free fatty acids are in the bloodstream, they basically beget free radicals, and those free radicals stimulate inflammatory pathways that basically compound the problem manyfold. So it's not surprising that vitamin E theoretically would be used. The problem with most vitamins, when you're trying to figure out what you need to suppress an inflammatory pathway, you don't know what the dose response is. So it's a guess.
Right, but most of these, I got a grant when I was at UMS. I got a research grant to study SAMe, S-adenosylmethionine. But it's the same mechanism as the vitamin E. It's to build the antioxidant amount in the liver. So it's only one aspect of the whole pathogenesis. But because we're scrambling for any treatment, any treatment would be anybody's hoping for something, but it attacks only one mechanism of the pathogenesis.
Particularly with a 70% prevalence in the world of fatty liver.
Yeah. So anyway, so vitamin E can be used, but the guidelines states that you can use it in somebody who does not have type 2 diabetes. So if they have NASH but they don't have type 2 diabetes, you can certainly give it a shot. I typically give it to the patient because it's relatively benign, but I try not to go beyond 1,000 because the studies on those children were 1,200 units. I probably wouldn't dare do more than 1,000, but 800 probably is reasonable. So who should be referred to a specialist? So first, I defined earlier what a specialist is. So not all specialists are the same. So within the gastroenterology field, it's a huge field. So within gastroenterology, then you have subspecialists within gastroenterology. So, but refer to somebody who gives importance to fatty liver disease and has knowledge of fatty liver disease. So patients who have persistently elevated transaminase, that's more than 30 units per liter, should be referred. Patients who have steatosis on imaging should be referred. And those certainly who have signs of advanced liver disease, meaning if they have cirrhosis, if they have signs of portal hypertension or complications thereof, they need to be referred to a specialist. Now, by the time they're cirrhotic and have portal hypertension, they have to be referred to a hepatologist. The GI doctors will reject them anyway. Let's see. So patients with type 2 diabetes are at high risk for NASH and advanced fibrosis. We talked about that earlier. and the patients with NAFLD have 2 to 5-fold risk of incidental diabetes. So that's more for us. So whenever I see a patient with fatty liver disease, I test them for diabetes and then refer them to you guys. So in conclusion, like I started, I said, and I hope I achieved the goal. Number one is to convince you or to prove to you that fatty liver disease is highly prevalent. Number two, that fatty liver disease is not a benign disease, that we shouldn't take it for granted, and it would be irresponsible to take it for granted and ignore it. And number three, it's a call to arms that we all have to work hard in identifying these patients, because if we don't, then this public health crisis will go uncontrolled, and we will end up burdening the economy of this country and or the whole world, and we will have more sick people than healthy people, and we will be in trouble.
So a lot of these people are going to have abnormal liver enzymes, and presumably dyslipidemia is playing a part of this related to obesity and all the other the usual suspects. So is there a point where you would say to an endocrinologist or a lipidologist in terms of transaminitis that using a statin may be particularly problematic?
For sure.
Because in some of these patients, things actually get better because the dyslipidemia gets better, which is causing the problem in the first place.
Yeah, so that's a great question. And so a common issue is a patient has dyslipidemia, and they see us because of their fatty liver disease. And the common situation is their physicians ask them to stop their statins. And I always write back on my consult and say, okay to use statin, and it's actually beneficial to treat the patient with statins. And I would say, I would take care of your patient. You treat, I'll take care of it. Yeah. I'll watch it. So in fact, people with dyslipidemia and have compensated cirrhosis or compensated liver disease should be treated. If they're decompensated, meaning they have encephalopathy, they have ascites, they have hepatoma, then you do not treat them with statins. But if they're compensated, they should be treated.
But a good portion of the patients that we see that have cirrhosis, or at least by their story that they had a biopsy or whatever, we don't generally review the biopsy, is that their liver enzymes are generally normal.
Yes. Okay, great question. See, I like Dr. Brad. He's my former partner, so we used to talk a lot about these things. So fatty liver disease. So in the past, people who are called cryptogenic cirrhosis, right? Because they have no known cause. They get a liver biopsy. They have no known cause. The liver biopsy looks bland. That's a problem. It's the cryptogenic cirrhosis are the fatty liver patient. It's called burnt out fat. So the fat gets burned out. So when you do a liver biopsy, by the time they're cirrhotic, it looks really bland. Like, where's the fat? There's no fat. So what's the cause of the cirrhosis? 99% of them are fatty liver disease. So, yeah. And on another point, so we talked about the statins. The other issue is Tylenol. So another struggle for us hepatologists is that patients who come to us, they start taking ibuprofen because their doctors ask them to stop the Tylenol because they have a liver disease. So this is what I always say. So it takes 8,000 milligrams a day to cause liver failure in somebody who is an alcoholic. So if somebody drinks alcohol and takes 8,000 milligrams of acetaminophen, they can go into acute liver failure. 8,000 milligrams, that's a lot. So I always tell the patients, acetaminophen liver injury is dose dependent. Ibuprofen liver injury is idiosyncratic. So you can take one dose of ibuprofen, 200 milligrams, and your liver and your kidney dies. But Tylenol is easier to manage because it's dose related. So if they're cirrhotic, I just tell them, well, you can at least take 2,000, you can take up to 2,000 milligrams of acetaminophen, and if you need more, give me a call, and I will interview you first and tell you if you can take more or not. So 2,000 milligrams a day compared to my limit of 8,000, that's quite a bit of room for allowance there. So. And finally, just a little plug. so Dr. Bao introduced my book, and So I published 2 books recently. I published my first book, the one on the left, Divine Intervention. I published that May of 2022. And this other book came out yesterday. It came out yesterday. This is part of my ministry work. So this is not a financial venture. Last year, or 2 years ago, I founded a ministry called Lucia Lux Ministry. So Lucia Lux is Latin for let your light shine. So the goal of the ministry is we want to serve God by serving our fellow men, women, and the goal here is to encourage, to inspire, and to give people hope. So that's the ministry. So you support my book, you're supporting the many people we're trying to help. So it's a budding ministry. We have a financial asset of about $75. But it's hard to make a profit out of selling books. I just realized that. There's really not much profit there. But if you know of anybody who's looking for hope, encouragement, get a book for yourself, for other people, for them. You're helping a ministry. So, thank you.